So, what is evidence-based medicine then? I like to think of it as three core principles. One principle is that some evidence is more trustworthy than other evidence. And so what evidence-based medicine provides is a way of distinguishing what is more and less trustworthy. Second, we do not want to have situations where people pick the study that appeals to them with the results that appeals to them, and that is a danger. And so we introduce the science of what are called systematic reviews of the literature. And that allows us to get a comprehensive look at the highest quality evidence available. And so second principle, we have a hierarchy of evidence, and now we want to get a representative sample of all the highest quality evidence to inform any clinical decision we make.
So, Gordon Guyatt, we're absolutely delighted you've come to speak to us, even if it is online. We're thrilled to meet you. We wonder, would you be able to start off by telling us, you're often described as the father of evidence-based medicine. Could you give a little introduction to our listeners and our audience about who you are and what evidence-based medicine has done to change the face of treatment for basically the whole world, really?
Sure. So I'm a faculty member at McMaster's University. As many successful academics, I stood on the shoulder of giants. A guy named Dave Sackett was my mentor and laid the groundwork for what became evidence-based medicine. In 1990, working with JAMA, we started what became planned and eventually became the user's guide to the medical literature. Well, first of all, I guess I should say, I published a paper in 1991, which was the one that introduced evidence-based medicine into the literature, but in a relatively obscure place that nobody much noticed. And in 1992, we published in JAMA the first paper that widely introduced evidence-based medicine as a term and the concept to the general readership. JAMA being the world's largest circulation journal, and the paper was prominent. That got a lot of attention. Then we started in partnership with JAMA to write the user's guide to the medical literature, which was our effort to do what had not been done before. Because what had not been done before is physicians and other health professionals did not receive any training whatsoever in how to read original studies. And this seemed like a problem. And so we had to create a curriculum for teaching medical students and residents and practicing physicians and people in the health professions, giving care to patients, how to read the medical literature. And this user's guide to the medical literature then became the curriculum for evidence-based medicine and has been widely adopted. And within a decade of the time we introduced it, it had very large uptake and was already becoming a sine qua non. That's something that institutions had to have to get their training programs licensed. They had to be training people in being able to use the medical literature. This was now recognized as something that should be very important for clinicians. So what is evidence-based medicine then? I like to think of it as three core principles. One principle is that some evidence is more trustworthy than other evidence. And so what evidence-based medicine provides is a way of distinguishing what is more and less trustworthy. Second, we do not want to have situations where people pick the study that appeals to them with the results that appeals to them, and that is a danger. And so we introduce the science of what are called systematic reviews of the literature. And that allows us to get a comprehensive look at the highest quality evidence available. And so, second principle, we have a hierarchy of evidence, and now we want to get a representative sample of all the highest quality evidence to inform any clinical decision we make. And we found out at the beginning in 1992, when that JAML paper that was the first major introduction of EBM to the worldwide audience, we weren't really aware of what became evident in the next few years, which is that evidence itself never tells us by itself what to do. It's always evidence in the context of values and preferences. So virtually every clinical decision, you're going to do A versus B. A has its advantages and disadvantages, and B has its advantages and disadvantages, and these have to be traded off by patients. And those involve value and preference assessments. So the third principle of evidence-based medicine is that evidence never tells you what to do. We have a hierarchy of evidence. We summarize it in systematic reviews, but that does not get you to a decision. Getting to a decision involves consideration of patient values and preferences. So these are the three key principles that, to me, define evidence-based medicine.
And is there a clinical expertise pillar? Is that one of the pillars?
It is built on the assumption of clinical expertise. So clearly, people have to be trained. They have to know how to take histories and physicals. They have to know the treatments that are available. They have to know how to talk to patients. I think that a critical skill that evidence-based medicine has highlighted is the need to ascertain patients' values and preferences. Since evidence-based medicine has got started, shared decision-making, which was not really around at all at a time that EBM got going. And, we were as culpable as anybody else at the beginning in not realizing, but subsequently, this value and preference pillar made us realize that shared decision-making is crucial to the practice of medicine. So there are all these basic clinical skills that are fundamental and underlying, and also clinical skills and the knowledge of one's content area when you're seeing patients. You have to, if you're in a specialist, you have to know your specialty well. If you're a primary care doc, you have to know the basics of the broad decisions of primary care.
And is there any condition that evidence-based medicine can't cover, or it's beyond evidence-based medicine?
No. If you're talking about medical, I presume we're talking about healthcare decisions. Okay?
Yeah.
It applies to any healthcare decision. So one of the there have been all sorts of misunderstandings of evidence-based medicine, and I'll tell you one parody of evidence-based medicine that points out what it is and is not. Is that the patient comes in, "Oh, doctor, I got this terrible pain. Help me, please." Doctor turns to the computer, turns back to the patient. "Sorry, can't help you. No randomized trials." So that is a parody of evidence-based medicine. Evidence-based medicine tells us how to navigate a situation when there are randomized trials and high-quality evidence, but it also tells us how to navigate the situation when the evidence is only low or very low quality.
And how do you think evidence-based medicine should be applied with regards to gender dysphoric children?
First of all, there needs to be a recognition that we only have very low quality or certainty evidence regarding the merits, the good things that, for instance, gender affirming care can achieve, and the things that it cannot achieve. And we generally say low certainty values and preferences are always important, but they are very important in the context of when there's very low or very low quality or certainty evidence. So certainly values and preferences of patients and families are important here, and patient autonomy is important. So that is, so that's one thing. And so efforts to, by legislatures to prevent access to certain aspects of gender-affirming care are extremely problematic from an evidence-based medicine perspective that places a high respect for patient values and preferences. That doesn't mean that you should simply, that any young person comes in and says, I want particular gender-affirming care and a particular intervention, and please give it to me, and you hand it out. That is not at all what it means. What it means, in my view, I am not an individual delivering such care. I'm not a pediatrician. I don't have expertise. But now, because of controversies that have arisen from the work we've done looking at the evidence, we did systematic reviews that demonstrated there was only low quality or certainty evidence. And that became very controversial. It became, in my view, misused by people who used it to try and argue that there should be legislative barriers to the delivery of care. That's not the appropriate conclusion from the work we have done. But at any rate, it's become evident that, to me, that adolescents may be legitimate questions arise as to whether they have the maturity to make some decisions, whether they're liable to, as time goes on, potentially regret decisions that have been made, and there needs to be appropriate shared decision making, which they need to be aware of there's only very low quality evidence about this, that the decisions they make now, they potentially may come to regret. There needs to be assessments to make sure they have the maturity to make the decisions. So, but in all of that, none of that denies the acknowledgement of the importance of patient autonomy.
So on that subject, because there is a lot of high quality evidence that adolescent development, identity development is fluid, and that adolescents do not have the capacity to make decisions that will impact their fertility or their future ability to breastfeed.
Hang on. That was a very unequivocal statement that you made. They do not have the capacity. I'm not a pediatrician, and I have noted with my own children and in lots of other places the limitations of adolescents' maturity in making decisions. You seem to have taken the position that, the way you put it there, no adolescent is capable of making the right decision about their future and something so important. That, to me, it may not be what you were intending, but that's what it sounded like, and I would not agree with that.
Well, I'm drawing on the literature that we have about adolescent development. For example, we don't offer vasectomies and tubal ligation to adolescents as birth control because we know that they can't make that decision. It's a permanent, irreversible decision. And so, to me, that suggests that adolescents just don't have the capacity to make decisions about fertility.
You will have to talk to experts who had been for a couple of decades giving this care in appropriate ways, which means vetting clearly there may be many adolescents who present with gender dysphoria in whom they don't have the maturity to do it. As I say, I'm not a pediatrician. I'm not an individual who is delivering this care. From having talking to people who do, those with expertise, some of those with expertise would argue that there are adolescents who after appropriate vetting and consideration, are able to make those decisions.
I hear you, but
can
I just...
like you may be You may be right and I may be wrong, and these people who deliver the care may be wrong. But my impression from talking to such individuals, that there are patients who are harmed by not allowing them to proceed with what they believe is right for them.
That's interesting. I wonder though, would evidence-based medicine surely have come across this many times before, that one of the pillars is, shared decision-making, the values and preferences of the patient. If the patient is 6, their ability to assess the situation is limited. If they're 12, it's also limited. As in, evidence-based medicine has come up against the maturity of the patient, or for example, if the person is highly vulnerable because of other mental health challenges. How does evidence-based medicine handle the fact that some people's judgment is very impaired and what they want is not necessarily what's good for them?
This may be, I can tell you what is in some ways an analogous situation. In others, you may say this is not analogous at all, but let me throw it out to you. I worked for close to 50 years as a general internal medicine specialist in a hospital setting. I did my last clinical week just a couple of weeks ago. 48 years after graduation. So I had to hang up my stethoscope. But again, you may say this is not analogous. I think it bears similarity. The situations that I had to deal with very frequently were people with mild cognitive impairment who were living alone and desperately were in the hospital now and desperately wanted to go home. And they felt that not going home is going to hugely compromise their quality of life. And the question is, are they safe to go home? And the situation was, okay, we respect autonomy. We see that these people really want to go home, but are they going to be safe? And we had to make a judgment. And the judgment has to do with, to extent, how you value you put in their safety and how the value you put in their autonomy and what they desire for themselves. And it was a patient by patient judgment call where we had to make the decision on their capacity. And, there's no right answer. It's a continuum. I'm not a pediatrician. I don't deal with these people. However, from talking to people who do, it seems to me it's a very parallel situation. That you may have majority, I don't know where, I don't know the proportion, I have no idea the proportions, but you will have some where the judgment is, however strongly the young person feels about what is right for them, we should not proceed because they don't have the maturity. Their risk is too much. There's you have the situations that you are talking about they have mental health problems, all sorts of reasons where you may say, okay, however strongly the person feels about it, it's not right for us to let this go forward. Or for the group. And it clearly needs to be a multidisciplinary group. Again, I have no real expertise at all in this area. But having talked to the people who do, it clearly has to be a multidisciplinary group that makes the assessment. However, I believe could be wrong. I'm not the one in the front lines. I do not do it. But talking to people who do, I get the impression that it is a judgment call and that there are at least, and I don't know the proportions, but there are at least some of the young people who, when you take them through and have the full discussion and the psychological or psychiatric assessment, et cetera, all the things that might reasonably and appropriately be done to allow one to make the judgment, keeping in mind that patient autonomy, you cannot, I believe, throw out the window. You need to take it into consideration with all the reservations that I've just suggested, but you can't throw it out completely. I may be wrong. Maybe it's the wrong thing to do in all the kids. Maybe in 100% of the kids, it's the wrong thing to do. From what I've heard, that seems unlikely.
But okay, may I quote? I've spent a long time listening to the experts who do provide this care. And there's one particular panel of experts, they were talking about this And one of the leading pediatric endocrinologists who puts these kids on this treatment said, talking to a 14-year-old about fertility preservation is like talking to a blank wall. They'll be like, ooh, baby's gross, which is classic.
Anecdote. Excellent anecdote of a single individual with a single opinion.
Well, so are you saying for a pediatrician who thinks it's like talking to a blank wall, he should not be putting these kids on this treatment, this particular pediatric
I think it needs
technologies?
multidisciplinary. Okay, I will say it now. I've said it once. I'll keep saying it. I am a total non-expert in this area. Everything you could dismiss everything. It might be quite appropriate to dismiss everything I have to say about this because I'm not a clinician who is delivering this care. Mm-hmm. I could tell you quite well about the difficult decisions about autonomy in cognitively impaired older people about whether they should go. Oh, I can talk about that with some authority, having done it for 4 years or so. Okay. I could not talk with any authority about this situation. However, I can talk authoritatively about evidence, and I can tell you about how much weight we should give to a single opinion about from a single individual. I can tell you about that.
I suppose I also have read extensively about this, like Mia, and I would wonder when you positioned gender-affirming care with the presumption that it was evidence-based, when gender-affirming care, in its entirety is pretty unsupported by any sort of long-term quality evidence as a treatment.
I told you, there's my analogy, okay? Well, it's not an analogy. There's my parody of evidence-based medicine. Patient comes to you, doctor, help me, please. You turn and say, sorry, there's only low-quality evidence.
Okay.
Please go home. I can't help you, okay?
What do you know? Okay.
I'll tell you another.
I get it.
That's
okay. Tell me another story because I have a question after that. Go on.
Okay. Personal experience. I do a lot of mountain biking. A couple of years ago, going over a bridge, I fell into a little river, had a quite non-trivial neck injury. I went to a chiropractor. I went to a physiotherapist. I went to an osteopath. They gave me all sorts of exercises to do. Pain in the butt, not fun. I didn't like it. And I did some of it. I didn't do all of it. A couple of years later, I had much better, maybe not 100% recovered, but I am much better. There was only very low quality evidence for all this advice that they were giving me. So should I have said, no low quality evidence, forget it? No, I have to make my decision as to whether I want to do what I want to do in the face of the low quality evidence. In this situation, I decide I know there's only low quality evidence. 2 years later, I'm considerably better.
Did it? That doesn't start off.
Wait till it
start up at all.
Anything to do? Did it have anything to do with those exercises? Maybe nothing. I was going to get just as much better whether I did the exercise, or maybe it really made a difference. I'll never know. Okay, so So the message is low quality evidence doesn't mean you don't do it. Low quality evidence means that all things have to be considered, upsides, downsides, risks, and so on. Clearly, this was a much easier situation to say, I'll go for all these therapies, but there's only low quality evidence because they were minimal harm, pain, but minimal harm, burden, minimal harm. This situation is much more tricky. There's no question, but the point is the same. Just because there's low quality evidence, you don't send the person out and say, sorry, can't help you, only low quality evidence. That is not that, I can tell you with confidence.
Okay.
Not
how has EBM, evidence-based medicine, how has it been impacted by the kind of rise of political activism, that political activists seek treatments, whether it's like it can be from different walks of life. It's not just trans. I do know other kind of conditions that political activists are kind of demanding treatment and they're receiving it. I think you had a question around that, Mia, and it was a question that you had brought up yourself, Gordon. It was about some activists that pushed for bone marrow transplants because of breast cancer.
Well, let me tell you the story of bone marrow transplants and breast cancer.
Yeah.
there were preliminary reports that suggested that bone marrow transplant could make people with breast cancer live longer. And people took this low quality evidence seriously. And for a while they were doing it. Randomized trials were done, no benefit. And then it stopped. Okay. So when you're in the preliminary situation of you have low quality evidence, then the decisions and the trade-offs are much more difficult. Once you have the high quality evidence and it settles the issue one way or the other, you're in a much better position.
But may I, because I looked into this bone marrow transplant, and it was a false premise, first of all, that they thought higher doses of chemo would be more effective, and that's why they needed to do the bone marrow transplant. So the women suffered, but based on uncontrolled low quality evidence, women's groups started pushing it as a human right, and people were bringing lawsuits demanding access to the treatment before there was evidence to say it was safe and beneficial.
No, before there was high quality evidence. So they can be very careful. There was evidence. People published studies suggesting that it was beneficial. It was only low quality evidence.
Well, there was no good quality evidence to say it was safe or beneficial. Do you see a parallel there with pediatric gender medicine?
Only if you, I feel manipulated at the moment. Okay, just to label that. What are the parallels? You have low quality evidence for doing something, and you have advocates, and you have individuals who are seeking the care in the face of low quality evidence. Okay, those are similarities in the situation.
Okay. And the bone marrow transplant turned out to be women suffered unnecessarily, and it wasn't.
In this situation, I would predict there is a subpart. I don't know. I'm not the clinical expert. Just from what I've heard, it may be quite appropriate to dismiss everything I say on this matter. And if you said, Guyatt, you don't know what you're talking about. You have no clinical expertise. You are making statements on the basis of what you heard from this person or that person. All you really know, Guyatt, is there's low quality evidence. So why don't you just shut up? Okay. If you said that to me, I would say you had a point. Okay. But if you want me to go on the impressions that I picked up, which may perhaps should not be taken seriously at all. But if you go on, I would predict that if the appropriate studies were done, we would find a subpopulation who would be harmed by not allowing them to move forward, and a subpopulation that if we do not vet properly would be harmed by letting them go forward. I would predict that if we do the studies, that is what is likely to happen. Given that that's the case, you can make what should be. So if I happen to be right about that, which I may not be, but if I do happen to be right, the appropriate way, as far as I can tell, to handle the situation is a very serious vetting process. The Finns are the best people in the world, as I understand it, who are doing this very well. A very serious vetting process where you have a multidisciplinary team, you have endocrinologists, you have psychologists, psychiatrists, I don't know who else, maybe other people, but some multidisciplinary team making the assessments and deciding in what situation you have a patient and family, of course, families need to be involved, who say maybe in the majority of situations, as I understand it, it is with the Finnish experience. But again, my everything I say, my knowledge is superficial. I've not gone into it in depth. What I can tell you, what I can say with authority is that the published evidence is low quality. And that's the end of what I can say with any authority. Anything I say beyond that, I do not speak with authority. But my understanding is they find in Finland, when people go through this process, they find a minority of the kids who appear to have a maturity, whom not allowing them to go forward with this would be harmful for them. They may be right and they may be wrong. It seems to me a sensible way to proceed. But once again, I'm not the expert. I'm not the person delivering.
And can we talk about medical necessity? Is that within evidence-based medicine? Is there a
I don't know what you mean.
what? Well, that's what I want to know. What in your mind is medically necessary? How do we define that
I don't.
treatment?
I don't. The term is not useful.
Okay, so it's got nothing to do with strength of evidence.
However, obviously decisions have to be strength of evidence. I don't know what you mean by medical necessity. It's not a term I use, nor am I familiar with.
Okay. Could I ask you, just as a matter of interest rather than anything to do with evidence-based medicine, do you view being transgender as something that's kind of within somebody?
Look, you're asking me about stuff that I know nothing about. Okay.
Okay.
I am not a clinician delivering care to these people. How can I possibly? I'll tell you something about evidence-based.
Okay.
It's allowed me to make a distinction between what I know and what I don't know. And people ask me also when I'm giving rounds. Okay, I give rounds about some evidence-based thing, and then somebody says, "Oh, what do you think we should do? The public really doesn't get it about evidence-based medicine. What should we do about it?" And my answer is, don't ask me. I haven't looked at the evidence about what people have studied, what we should do about changing public opinion. That's not an issue that I know very much about. And so I would be foolish to give you an answer because I don't know. Okay. So
I suppose I gathered
if you ask me the question, what do I think about the nature of gender dysphoria? I know nothing about the nature of gender dysphoria, and I'd be a dope to try and offer.
Okay, well, I have an open question then for you. I get it. Yeah, you're evidence-based and don't ask you to go beyond that. So what did happen with the kind of the series of events that you did some 5 systematic reviews with SEGM and then 3 were published? Could you just tell us the kind of series of events that happened around that?
Well, we covered the reviews, and then they were egregiously misused. So
By whom?
By the governments, by the Alberta government, by HHS, Human Health Services in the United States, by 20 or something states in the United States, which used our work to justify denying care to people. That was egregious, unconscionable misuse of our work.
But do you think that it was just your work, or do you think...
No. But I'll tell you, read the HHS report, and you will see a whole chapter about evidence that largely relies on our work. If you look at what was just published in the National Post in Canada recently, they say, the Alberta government, the medical profession is pushing back against the Alberta government, which has put legislation to deny the care.
May I say...
Can I finish this? Okay. And the National Post publishes an editorial. Oh, the medical professions are all wrong. Guyatt's work shows there's only low quality evidence, therefore we should deny care to people. Okay. And I write a letter. That's not how you should be interpreting our work. And they don't publish my letter. So it's been kind of frustrating to get the message out. I'm telling you, I'm sure there's lots of other things that bear on this, but I can tell you unequivocally, our work has been predominantly used to justify denying care.
Well, okay, I want to go back to the HHS report because I've read it from cover to cover. And so, yes, there is a section on the evidence, which just assesses the evidence, the strength of, the weakness, whatever. And then there's also a really important section on ethics. Have you read the ethics section?
Yes, I have.
So it deals with the social factor, the cultural factor, the lack of capacity to consent, the interventions, how the evidence of harm outweighs evidence of benefit. So they're not just using your systematic reviews to justify banning this treatment.
In treatment.
They're looking at the entire picture.
Are you denying that they cite our evidence prominently in justifying your decision? You deny that.
In the evidence section, it features prominently, but they're taking into consideration the ethics, the autonomy, the capacity, the social factors, the cultural factors.
Of course. But did they not cite our work prominently to justify their decision? Yes or no?
I can't say prominently to justify it. It was a factor. The low evidence is a factor.
We may have a disagreement. It seems like we both agree that they took it into account, and their chapter in the evidence, which played into their ultimate decision, relied largely on our work.
Okay, sorry, Stella, go.
I just thought there's nowhere in evidence-based medicine, there's nowhere in the 3 pillars that says, and if people use the evidence in a way that you don't like, you need to withdraw it. There's nowhere that this is a scientific...
What about... Where do you get about withdrawing anything?
Well, I suppose you've added a paragraph.
Where? I'm sorry, I'm not sure where this withdrawal.
No, maybe not withdraw, but is there another area of medicine where you would consider it egregious to factor in low quality evidence, to place restrictions? Is it only egregious in gender medicine, or would it be egregious in another field of medicine to restrict based on low evidence and ethics?
I'm sure one could imagine, but with sufficient imagination, you could come up with something else.
I can't. I've thought deeply about it, and I can't. Can you?
Can think of another situation where you would... Oh, yes, I can think of one. If you had told me you can't go to a chiropractor, you can't go to a physiotherapist, you can't go to a osteopath, thank you, because there's only low quality evidence, therefore we will not let you do it.
But you missed my point. I'm talking about, is there another area of medicine where the patient population, there are serious concerns about capacity to consent because of age or whatever. There's low quality evidence, and there's strong evidence that we've got some sort of social contagion, psychiatric epidemic generating a large number of the patients. Putting all of that together, let's say it's not gender medicine, it's something else. Would it be egregious to take the low quality evidence?
It would depend on whether you believe that there is a subpopulation that might benefit. Okay. And you take, there's low, there, if I had to make the decision about, or at least participate in the decisions about sending people home where they might not be safe at home. There was no great quality evidence telling me, well, under which circumstances, no great predictive evidence saying to predict, but I had to make the decision, or I have participated in the decision. So there is a situation. So I could have said, mild cognitive impairment, nobody goes home. Okay. Or
the big difference is the political activism. There's a massive global political.
Yeah, so how do you deal with news clubs? But the political, I don't see how the political activism bears on what the right thing to do is. You need to, political activism or no political activism, you have to, somebody, you can say, okay, no kid, no matter what the circumstances, no matter how mature they appear to be, no matter how the parents think the right thing is, no matter when their gender dysphoria started, et cetera, et cetera. No, doesn't matter. We say no to everybody. You could take that position. Strikes me as not the right position, but I could be wrong, and I'm not an expert.
Is there, I may have understood evidence-based medicine slightly wrong on this, but is there, when my understanding is if there's low evidence, you can still make strong recommendations based on low evidence in certain circumstances, such as life-threatening conditions or whatever. But you can also, make strong recommendations against treatment if the risk-benefit ratio is such that the risks far outweigh the supposed benefits, the proposed benefits. Is that true?
Yeah, sure. But don't equate a strong recommendation against as passing legislation to forbid people from accessing treatment. Do not confuse those two.
Do you want to go ahead, Mia?
I think we don't actually disagree. Now I'm thinking about it. I think we don't disagree as much as I first thought, because in an ideal world where the medical profession can regulate itself, I am not in favor of bans, because it's not, the governments don't understand, like politicians don't understand. So I would support I would not support the bans if the medical profession could demonstrate to me that it could regulate itself. But the field of gender medicine exists outside of normal medicine. They're not guided by evidence, by science, by traditional medical ethics.
Okay, sorry, you're painting the wide diversity as I understand it. I have to qualify my non-expertise over and over and over again. But as I understand it, there's an extreme diversity in practice, and you're tarring everybody with the same brush, which, as I understand it, is a mistake.
How much do you know about the standards of care of WPATH and all of the standards of care in the field and the clinical guidelines?
Not much. However, I know enough to know that there is problematic. My strong impression is that there's problematic care being delivered.
Right. So if the entire field follows WPATH standards of care,
who with any sense is saying that the latest I understand, there's now diversity within WPATH community about what they think should be done. Okay. But if you and as I've learned more about this, the epidemiology of the situation has changed a lot. WPATH might have made sense, at the beginning when it was a very different population that was presenting. The population has changed dramatically. And anybody who says we should take the WPATH, it seems to me, anybody who says take the WPATH approach in the current epidemiologic situation, that seems clearly inappropriate.
Okay.
The thing I was wondering was, you added, yourself and some colleagues added a paragraph to all the systematic reviews that you authored with SEGM to emphasize the importance of patient autonomy and to denounce policies restricting medical interventions to avoid misuse. To me, that was a jump out of evidence medicine and a jump into kind of shaping people's minds around the evidence. But how do you think that additional paragraph has shaped the evidence?
What do you mean, how it shaped the evidence?
Well, how has it shaped people's readings of those reviews? What is the fallout of you adding?
I don't know. I haven't surveyed people.
Well, you haven't, but you wrote it, so you certainly would have given.
Not how I hoped it would affect. Here, how it has affected.
I said, how did you think?
Just a minute. To find out how it has affected, you have to do surveys to see how people react, as far as I know.
Okay, well, I just want to clarify. I certainly hope I said, how do you think it will impact SEGM? How do you think?
I thought you said, how does it impact? How does it impact what?
How do you think it's going to impact people's reading of this research? The fact that you've added this.
Well, I would hope they would start to use it as intended.
Which is
to inform the people making the decision that there's only low quality evidence and you'd better be careful.
And isn't that how it was used? It was used, you better be careful because there's low quality evidence and these children are statistically much more likely to be very vulnerable, and therefore you probably shouldn't carry out irreversible medical interventions on them.
That's your opinion. There are people with different opinions who has expertise in the field. You can take your position, obviously, and other people could say there's at least a subpopulation in which it should be done. When you balance all the risks and benefits, it's a tough call. But there may be some people who do. You think it shouldn't be done in anybody? I don't know. maybe
And I-
maybe 100% of the people will regret it. That does not seem to be the case. But we you need to. There needs to be much better.
I'm aware of the people who wrote the statement were moved to make a donation to a pro-LGBTQ
group whose mandate was to work against legislative forbidding. That was the mandate of the group, which led to the donation.
And that particular group calls this treatment life-saving, medically necessary.
Not a good idea. They were the donation was.
How much was the donation?
A number of us were asked to donate to the group. We were told that the group that this money will go to the group's work to work against legislation forbidding the therapy.
But they work against that legislation because they call it medically necessary and life-saving, and neither of those statements are true. But you've given them money. That seems like you're endorsing those messages.
I can see why you say that, but that was not the intent. The intent was only about the work to against the legislative forbidding. That was the intent. To the extent that I can see that maybe that it could be misinterpreted, but that was the intent.
And activists, so this whole thing blew up, but the activists who they're quite aggressive, they're harassing, or I've seen the videos. You published the statement, and then they wasted no time in publishing an open letter demanding a retraction of the systematic reviews and an investigation. And it's signed by a large number of McMaster faculty. And that's my understanding.
You know something I don't. I thought it was an isolated couple of McMaster faculty.
Oh goodness, I scrolled. There was I can pull it up on my phone and fact check myself. I'll do that in a second.
How many do you think? How many?
Let me have a scroll. But can I just? So my question is,
I haven't. That's just to be clear. I had it. What you just told me. It may well be true. I had not been aware. Nobody told me that there were McMaster faculty.
Okay, I have to fact check myself.
No. You may be right. I'm just telling you, I haven't heard about it.
No, but they're calling for a retraction, and my understanding is there was absolutely nothing wrong with the way the reviews were conducted.
There's no way. We have no intention of retract.
Okay.
Have you ever added a similar paragraph to any work that you've done in your life?
Depends what you mean by similar. The
paragraph that says, "Don't misuse this work."
Just a minute. All the time, researchers, sometimes inappropriately, they publish a paper that is supposed to be the evidence, and they go beyond that to make strong suggestions about how their work to use. That is endemic in academic medicine. Okay, so it's no big surprise that people say, here's how we think our work should be interpreted and used. And there's lots of other times where we have said, here's how. Now, we try to be careful, okay? I think we try to be more careful than other people. We say, given, when I do systematic reviews and I say, here's how I think it should be used, I try to specify the underlying values and preferences because we know evidence never tells you what to do. It's always evidence in terms of values and preferences. So, to take simple medical examples, people should use antithrombotic agents if they put a high value on preventing stroke, but not if they put a high value on preventing bleeds, for instance. Okay. So we have said, what we have said is we think autonomy is an important value. And to the extent that you think autonomy is an important value, here are the implications. If you don't think autonomy, if you don't care, we don't care about autonomy. Autonomy has zero value. And this is what, when I've interacted with the second people, I say, you guys seem to think autonomy has zero value. I can't agree with that. Okay. So this is continued. If you think autonomy has different value and that's zero value, then don't pay attention to what we say, because we happen to think that autonomy has some value and should be taken into consideration.
In this unique situation, I think autonomy, you have to be very cautious because these young people are immersed in a culture saturated with the messaging of trans rights. They're online watching trans influencers and they don't. I firmly believe they don't have the capacity to make decisions.
You believe 100% don't have the capacity. Dude, I certainly agree there's some who don't have the capacity, and I certainly agree with your first statement that one must be cautious.
Right. I found it. It's you've got a good 30 or so faculty at least who've signed.
There's 1,000 faculty members in the health.
It's signed by 271 so far. It's growing all the time, but it's not faculty. About from a quick glance, 30 or so, and then alumni, and then trans activists, and it's growing.
Nice distortion there. Okay. So 271, most of whom have nothing to do with that. And you're absolutely right that you have a substantial, although not huge. I'm surprised it's only 271 if you're counting all the transactions.
I don't believe I distorted anything. What did I distort there?
Okay, I apologize. I'm getting a little emotional and I shouldn't have said that. I apologize. Okay.
Could I ask what happened with McMaster?
You started at 271. What? 271?
No, I was very clear.
I apologize.
Yeah, we're all friends. Could I ask what happened with McMaster? Like, how did they respond that there was this, big paragraph added and pulling out of the future reviews and things? What was the sequence of events that happened that it seems that McMaster went into a contract with Segum in 2021, and then it looks like to somebody like myself and Mia, through activist pressure, bowed out?
So, are you talking about relationships with Segum now?
Yeah.
Okay, I can talk about that, Okay, so my colleague back around 2021, I believe, with whom have taken a mentorship role, came to me and said, this Segum group is asking us to do some review. And I said, well, what do you think of this Segum group? Well, they seem to be quite reasonable to me. And I said, okay, if they seem quite reasonable to you, maybe we could collaborate. I then went to this Segum meeting and they seemed very problematic to me. So they were, because I fought with them through the whole Segum meeting. Because
it was the conference in New York in 2020.
And then to their credit, 6 of them got together and said, Guy, we want to talk to you for another hour. And at the end of it, the chair said, thank you for sparring with us for the last hour. Okay. So, and the point being that, the essential point being, they're putting zero value on a thought. I have problems.
And what did McMaster say? Or was it just you and your colleagues who said, we've got to get out of this. We got into something. We shouldn't have got into it. How do we get out of it? Well, what happened?
The decision was that decision was on the signatories of that statement.
And have you ever done anything like that before?
Done anything like what?
Well, released a statement to denounce the policies that have been enacted as a consequence of your...
Not that I can recall.
I think I'm going to ask...
This has been a unique situation for me in a number of ways.
And that reflects the fact that the entire field of gender medicine is unique, I think. What we're dealing with there aren't really parallels that we can all compare to because it's so.
Well, although the breast cancer example you gave, in terms of or the HIV community at the beginning with HIV care, you have the parallels of a group with a health problem.
Well, though, to be honest, I would go somewhere else. Have you heard the concept of tooth fairy science?
No.
Where that, it's a fundamentally flawed premise in the first place. So you might scientifically study how much the tooth fairy is giving and how often they give it and what time at night they give the money, but actually the fundamental basis of it.
You folks have made your decisions. Okay, that's fine. Why don't we just say you believe that no kid can ever have the autonomy to make the decision. So as a result, we'll dispense with, as I'd like Saga, we'll dispense with autonomy and just say no and say no kid ever has. Okay. But I'm ignorant, right? Maybe you know much better than I.
Can I give you a hypothetical then? Let's just say a branch of it.
No. We only have 3 minutes left. So, and you can't argue these things with hypotheticals. You have to stick to the situation.
Well, I mean, it can help though. It's okay. I'll ask a different question. Mike, can I ask my final question is, so there's been lots of people talking about the whole McMaster statement and everything. And somebody recently said that the very fact that you have signed this statement that says, I don't know, this is medically necessary. It's unconscionable.
How ridiculous. We never said anything. I told you that I would never use the term medically necessary in the law. I would never use it. The fact that you just say we said it was medically necessary is completely wrong.
Okay, well then let me fact check myself.
I think you missed the.
No, let me just fact check myself because
you can find medical necessary in my state. I'll have to jump off a bridge if you do.
Okay, Stella, you ask your last question while I.
To strike the promotion, I'm gonna put my money down. Look, Gordon didn't say it, but I'm very interested now suddenly to see it. Gordon, what I'd like to ask you, is there something you'd like to say about the whole what's just happened, so that people can be clear on your position, just in a nutshell, so that go on, Leah, go ahead, and then we'll.
Yes, there are enormous problems in the care that is given to gender dysphoric people. The care needs to be tremendously improved. That the medical profession needs to take some responsibility for improving the situation and set standards of care like we do. You don't let people who don't know how to do neurosurgery into a neurosurgery operation. Okay. So the whole of medicine has, and people get called up before the colleges when they're not practicing. There need to be appropriate standards of care that reflect the issues of harm reduction, harm in both ways, harm when people get the interventions that turn out to be harmful for them, and harm reduction if there are such people. I happen to think there are, but I'm very superficial in my knowledge, as I've said over and over again. Harm reduction in terms of benign care when people really are going to benefit from it. And that patient autonomy needs to be considered, but it should be shared decision-making that should be cautious and deal with all the reservations that you folks have suggested, but that does not dismiss out of hand patient autonomy and the possibility that there may be some people who benefit.
Okay. And I'll close on, I did fact check myself. This is your statement from August 14th. The final paragraph: we will no longer accept funding from SEGM. As recommended by community advocates, we have also personally made a donation to EGAL's legal and justice work, noting their litigation efforts aimed at preventing the denial of medically necessary care for gender diverse youth.
Okay. Okay. that was not my paragraph, and I didn't read carefully enough. So congratulations. That
You signed something that you didn't read carefully?
apparently, so I would obviously, if I had, well, what I paid attention to was the part that I wrote. If you want to know what I think, read the part that I clearly wrote.
I can't finish this conversation without saying that I feel very nervous that somebody of your eminence, and you have extraordinary eminence, I do understand the feeling of when you get invited into something and you went in good faith and it's kind of gone fairly weird. And you're kind of thinking, man, this is not where I'm at. I don't have expertise in this area. But what saddens me is that you are abdicating responsibility. You did go in, so perhaps it was your job, therefore, to stay in and educate yourself fully. So what you knew about it.
I got 100 million things that I had, 100 million balls in the air. I have no reservations. I found out enough. I went through these second meetings, talked to a whole bunch of people. I found out enough to, at the end of this, the position that I just expressed a few months ago, you asked me for a few minutes ago, you asked me for a summary. I'm very comfortable with that summary. I think I know enough. I know enough to think that makes sense.
But you signed a statement with something that very definitely goes against your position, which is medically necessary, is the phrase.
Sorry, but to pick that out, that was in the context of is inappropriate. Yeah, sure. I should have read the last slide, but that part of it was not what my focus was. If you can say, do I think this is medically necessary? It's not medically necessary, but I don't even, as I told you earlier on, I don't even use the term medical necessary. You asked me, what do you think about medical necessary? I said, I never used the term.
I do now, though, because you signed something that...
Come on,
Oh, I have to. The fallout has been so immense. It's been so big.
Don't pillory me for not having read something more carefully that I should have read.
But I have to give you your due. You rose to the position you rose to because of extraordinary work. And therefore we expect extraordinary responsibility and work from you. And I'm afraid you've kind of discredited yourself by signing something with a paragraph that clearly you don't hold with, and that is going to be positioned with your name.
What I wrote, okay, I was a dope. Okay, I'm sometimes a dope. I'm often a dope. What I looked at was, we are supporting this because of the act against the legislation. That's what I took away. That's what I took away from it.
But you were afraid to be destroying 4 years' work of second. This was not a minor little I'm a dope situation. This was a phenomenal.
You're disappointed with me and it's too bad and so on and so forth. But you're picking out a couple of words. Why don't you just focus on the overall message that I'm giving? Right? And look what stand by.
I'm focusing on exactly that. The overall message is denigrating the great work that has been done by SEGM for the last 4 years. And that's why I'm so concerned about it, because this carries a lot of weight.
I have big problems with SEGM's approach, and I continue to have big problems. I'm interacting now quite a bit with the SEGM people. I'm talking to them, and I'm talking to this Finnish woman in the next little while. Who does, and the Finnish approach to it seems like a very good approach to me. And if SEGM got up and said, for instance, we advocate the Finnish approach, and we think it's a terrible, and which respects patient autonomy, and we say they come up unequivocally against denial of care by legislators, I have no problem. But I've asked them to do that. I said, okay.
Can I just say one last thing? One last thing. This whole idea of patient autonomy and stuff, this is back to the kind of how insistent, persistent, and consistent the patient is. And I know for myself as a child, I had extreme gender dysphoria, therefore I'm biased because I moved out of it. However, my strength of personality would have carried the day. And so this idea that the very strong personalities will get the treatment they wish, because no matter what age they are, is such a flawed model. And I know you just fundamentally believe in patient autonomy, but when they're a child and they have very strong personalities and they have autistic traits and there's a political movement behind them, you are really missing a huge amount of patient autonomy.
Clearly, the psychiatrist should be able to make make an assessment of the sort of things you're talking about. And maybe they can.
That's right.
I don't know. I'm not an expert. Maybe they can.
We are, though.
Without a crystal ball, they can't. And most will admit that there's no way to know who will persist and who will desist. So
I'm going to talk to this Finnish woman who thinks they can. So maybe she's wrong.
Kaltiala, I'm not entirely sure she thinks they can, but maybe we should talk to her too, Stella.
I'll have a chat with her and see what she thinks.
Okay.
So,
Okay. Thank you so much. Thank you to see you again.